Okay. Okay, hi everybody. Sorry for a little delay. There was a little technical difficulty getting started. I'm Dr. Jamie Mitchell. I'm an endocrine surgeon and I'm the medical director at the Northern Parathyroid Center in Tampa, Florida, and the director of the Parathyroid Surgery Division at the Hospital for Endocrine Surgery, which you can see pictured behind me. A really special, great hospital designed. We were able to design entirely for the care of endocrine surgery patients, and I feel pretty fortunate to be able to work there. So I've got a few of these question sessions on Facebook, and people seem to have some interest, so we're going to go through some questions that you guys have been sending in over the last few weeks. You're welcome to send some in as we go along, and I will get to as many of them as I can. Hopefully it'll be helpful for everybody watching. Let's start with a pretty good one. This question is, can high calcium be a result of low vitamin D or low vitamin D levels and not hyperparathyroidism? It's a really good question, because this is something I see mismanaged with patients very frequently. And so a patient will be evaluated by the doctor with clearly high calcium levels, high normal or elevated PTH levels, usually elevated, and their 25 hydroxy vitamin D level will be low, variably low. And the patient is often told by their doctor, we need to replete your vitamin D with high-dose vitamin D supplementation to make sure that these abnormal values are not from your low vitamin D levels. So that is incorrect thinking, and if your doctor is trying to have you do that, please don't do it. The reason is the following. Vitamin D deficiency can cause an elevation of parathyroid hormone levels. It's a compensatory reaction. However, vitamin D deficiency can never cause hypercalcemia ever. What does happen, and why this is a classic pattern of labs for a patient with hyperparathyroidism, is that parathyroid hormone, one of the ways it raises your calcium up to normal when it's too low, which is what its job is by converting vitamin D, the 25 hydroxy form that your doctor is measuring, to its more active 125 dihydroxy form. That helps you absorb calcium from your GI tract. So when you have hyperparathyroidism and you're over-secreting parathyroid hormone, you're constantly converting 25 hydroxy vitamin D to a different form, and that's why it gets depleted. And so that's the difference. If your calcium is low and you have a low vitamin D and a high PTH, then vitamin D can help. If your calcium's high, the vitamin D being low has nothing to do with that. Okay? It's a great question. I see that come up a lot. This is an interesting question. I've had 2 surgeries 10 years apart. My sister and mother have both been diagnosed with hyperparathyroidism as well. Do you recommend yearly testing for other family members? It's a complicated question. While it's pretty unusual, there are hereditary forms of hyperparathyroidism. The most common being, it's not common, but one of the most well-known are called the multiple endocrine neoplasia syndromes. There's 2 types, MEN1 and MEN2. They're both well-described mutations, and they cause a number of things. They cause a number of neuroendocrine tumors, including hyperparathyroidism. All patients who have those mutations get parathyroid disease, and it's always 4-gland disease. It always affects all 4 of your glands. And so I don't know if you've been tested or if that's what we're talking about. There's also a non-MEN familial hyperparathyroidism mutation that causes hyperparathyroidism in those patients affected, but none of the other neuroendocrine tumors that I was mentioning before. Any of those genetic syndromes, those mutations can be tested for. They're just blood tests. I'm not sure if your family has been tested for those or not, but with 3 first-degree family members like you're describing, there's a good chance that you have one of these syndromes, and they can just be tested for. If you're the best thing to do with any other family members, kids of yours or other siblings who have been diagnosed, is to get the genetic testing and sort out what's going on. Okay, here's a good question. This patient had an operation. My surgeon removed 2 parathyroid glands but could not find the other 2, and my levels are still elevated. Should I continue to monitor? I think the question is there anything else we can do about this? Are there other surgical options? And the answer is yes. I evaluate a lot of patients who've had unsuccessful surgeries, and without knowing the details of this one, it's possible, or I've seen a number of instances where normal parathyroid glands are removed when a tumor can't be found, and so there's almost always an option to get you cured. It's more complicated because you've had a surgery before, but I do probably 1 to 2 reoperative parathyroid surgeries every day now, and so I've got quite a bit of experience with it. I'm pretty excited to tackle those cases and get them solved. So depending on when you had the surgery, sometimes you do need to monitor for a little bit, but I would recommend reaching out to the center. I'd love to evaluate your case and see what we could do to get you cured, okay? Let's see, is another reoperative case. This is a good one. So this patient had an unsuccessful surgery. I had a parathyroidectomy in October of this year where they did not remove parathyroid glands. They thought they removed a tumor, but it was a thyroid nodule. It goes on to say, CT scan shows my parathyroid is intrathyroidal. That means a parathyroid tumor inside the thyroid gland, which can occur. What should I be aware of with this, and when should I seek a reoperation? A couple things. Intraoperative parathyroid tumors is a common reason that people or patients can have failed operations, particularly if it's an inexperienced surgeon. And also if the surgeon does not perform their own ultrasound exams of the neck and the thyroid before their surgeries. I think that's a critical part to evaluating a patient who's doing an ultrasound yourself as a surgeon. And so that's important. I'm not sure, I'm assuming that this surgeon maybe didn't do that. One thing I'll say about a CT scan showing an intrathyroidal parathyroid, I think CTs are very imprecise for making that particular diagnosis, frankly. The best imaging test to prove or to ascertain if a patient has an intrathyroidal parathyroid tumor is ultrasound, without a doubt. So, for example, if I were evaluating you, I would not tell you that I'm certain you have an intrathyroidal parathyroid tumor until I had done an ultrasound to really evaluate that. It's certainly possible, but I would say, or when to seek reoperation. If it's been 6 months since your surgery, then I would be, depending on the circumstances and what was done, etc. 6 months is sort of when I would go back in for a second operation. It's about the earliest that I would do it. So if it's been 6 months and you're interested, again, I encourage you to reach out. I'd love to evaluate your case. Next question. This one's from Ireland, actually. My calcium and PTH have remained high after surgery here in Ireland, where they did not check all 4 glands. My symptoms are excruciating. What pre-test do you require to be seen? We don't really require that much, to be honest. All we need is your lab work, preferably the labs that you had before your surgery and any lab data that you've had since, and the details of the operation and path reports. That's very helpful when I'm trying to evaluate someone for a second operation, so we can tell exactly what was done, what was removed, etc. So if you can obtain and send us your lab data before and after surgery, and your operative report and path reports from your surgery, that's really all I need to see. Okay, I encourage you to do it. I'd love to evaluate your case as well. Well, let's see. After having 2 glands removed, will I need calcium supplements for the rest of my life? Citracal is hard to swallow. Do you recommend any others? I'm going to make the assumption that you were cured by having your 2 parathyroid glands removed. And the answer is you don't need to take calcium supplements for the rest of your life. The only time you need to do that is if you have no parathyroid glands remaining, and that's pretty rare, okay? And no surgeon would purposely do that. So if you have 2 glands left, that's 1 more than you need. And while we recommend calcium supplementation for the short period after surgery because it's usually required, and if you have any evidence of bone loss from this disease, taking calcium supplements for a period of time, usually a few years, can help you to regenerate your skeleton and your bone density as much as possible. That's not something that you need to do for the rest of your life. You do not need to stick with Citracal. There's plenty of other forms of calcium that you can use. Tums calcium carbonate is fine. There's chewable calcium. There are actually liquid forms of calcium that you can find. So if you're having trouble with the supplementation and you want to continue it, you go to the pharmacy, talk to the pharmacist if you have to, but you will be able to find a form that's a bit more easy for you to take, okay? Okay, let's see. When should I be tested again after surgery? How often going forward? I'm going to assume that you had a successful operation and you're cured. Usually, the way we do surgery at our center, where we identify all 4 glands during every operation, we check a parathyroid hormone level in the recovery room, and so we know before the patient leaves if they're cured or not, based on the findings in the operating room and that PTH value. We still do recommend that they get a lab test in 1 to 2 months, just to kind of cross all the T's and dot all the I's, so to speak. And if those lab data look normal, then you really don't need to check these data frequently. Really just a calcium level at your annual checkup, if you're old enough to need an annual physical, really is all that you need to do going forward. You don't need to get fancy tests or parathyroid hormone levels even, just a calcium is what should suffice. This is kind of an insurance question. I guess it's an important one. Does Medicare cover this surgery? Medicare always covers this, and that includes people from any part of this country. You don't have to be in Florida, you can be in any state of the United States, and if you have Medicare, it will cover this. Medicaid is a different story, but Medicare, yes, always covers this operation, even if you're coming from out of state, okay? Let's see. This is a tough one. I've had 4 parathyroid operations and have not been cured. I still have high calcium. What do you recommend I do? It's an easy question for me, actually. I recommend that you get in touch with our center and do a consultation with me. I'd love to evaluate your case. I think the most surgeries that a patient has had that I've been successful fixing is 7 operations that were unsuccessful. So it's possible. Obviously it's complicated, but like I said before, I love doing these cases and get pretty excited about trying to solve them. So if you can, go to parathyroid.com, and the intake process is pretty easy. I'd love to evaluate your case and see what we can do for you. Let's see, this is kind of similar to the question we had before. I had surgery, successful surgery with Dr. Mitchell in 2022, where subtotal parathyroidectomy was performed. I only have 1 parathyroid gland left. Is it ever possible for me to stop taking calcium supplements? The answer is yes. You only need 1 parathyroid gland to have normal parathyroid function, which means you should not need to take calcium supplements. So interestingly, our bodies do not know the difference if we have 4 parathyroid glands or if we have 1 parathyroid gland. They all do the same thing. 1 does as good a job as 4 do. It's a redundant sort of system, so to speak. And so as long as you have 1 healthy gland left, which it sounds like you do, you can stop taking the calcium. I think part of the question was how do I know if it's okay to stop? Just stop taking them. You know, I'm not sure how long it's been since your surgery, but it's been a year, it sounds like. Stop taking them, see how you feel. If you feel okay, you can have your doctor check your labs, in a few weeks or a month or so, something like that. And if your calcium is okay, then you're fine, which it should be. Okay. This is a question about how to find a good endocrinologist. What should I look for? That's it's a difficult question to answer, but there's one comment I would make. Endocrinologists, just like most medical specialists these days, tend to specialize within their specialty, so to speak. So there are some endocrinologists who are really good at thyroid and parathyroid disease and their management. There are some endocrinologists who don't do very much of that. They're diabetologists, they just take care of diabetes primarily. There are some endocrinologists who focus primarily on pituitary disease and things of that nature. Some specialize in bone metabolism. So what I would recommend is looking at the endocrinologist in your area if you're trying to see one, seeing if you can, or calling their office to find out if they have an area of specialty within endocrinology. You should be able to find an endocrinologist who has an area of interest or more of a focus in thyroid and parathyroid disease, if that's what you're looking for. Okay, that's what I would recommend. Let's see, I sort of already did that one. Let's see. Here's a pretty good question. Why would PTH stay elevated after removal of an adenoma in 2017? I'm going to have to make an assumption here again to answer this. I'm going to assume that you were cured, like your calcium has normalized, etc., but your PTH maybe has become elevated again or remained elevated after surgery. It's not that uncommon to see this, where you have a straightforward operation, even here, where we always identify all 4 glands, so we know we found them all, etc. And if it's straightforward and we remove a parathyroid tumor and the 3 other glands are normal and are tested, and yet patients will call back or they'll call me or email me and say, hey, my PTH is a little high, what's going on? They get nervous about it. It's not that uncommon. There's some theories about why this is, and the key is if your calcium has normalized, that's the key. You're probably fine. One theory is that when you have active parathyroid disease, you're constantly telling your skeleton to dissolve itself, essentially. And when you treat this problem and cure parathyroid disease, that process reverses. So the skeleton starts to really actively take calcium back up into itself from your bloodstream. And in some people, it can remain pretty vigorous for a period of time. And the thought is that as that happens, it continues to lower your calcium levels, and your parathyroid glands secrete more hormone in response to that. And so the PTH remains a bit elevated to kind of counteract that process. That's the most common theory, the most common reason for this. Again, as long as your calcium levels are not elevated, it's probably fine. That's probably what's going on, and not anything to worry about. Okay. Let's see. This is a tough one to answer. This patient says that they had a 1.2 centimeter adenoma removed, and my calcium did not improve at all. The question is it possible for a healthy gland to be this large? It's a tough question. It's possible. I mean, it depends what was removed and how your pathologist interprets the weight of the tissue, because a parathyroid gland can be removed with a lot of surrounding thymic tissue or fatty tissue that's around it. And if the pathologist weighs it all together, it can seem pretty big. 1.2 centimeters is large for a parathyroid, but if it's other tissue that they're including that, then maybe it's misleading. More likely, this was an abnormal gland and you just have another one. You have another abnormal gland. It's not that unusual. 30% of people who have this disease have more than one adenoma. So it's not the majority, but 30% is pretty high. So 3 out of 10, 1 in 3. That's the more likely scenario than that this was a healthy gland. Okay. Let's see, what should calcium levels be for someone in their 70s? Really, anybody above age 40, your calcium level should be in the 9 milligram per deciliter range. That's the US system. I'm not sure where this question comes from, but in the US system, that's the concentration that we use for calcium measurements. It's milligrams per deciliter, and somewhere in the 9 range is what you should be at. In general, if it's above 10.0, if you're in the 10 range, even though a lot of assays will say that up to 10.5 is normal, that's really elevated for anyone above age 40. It doesn't really, it doesn't correct for age, because when you're young and you're building a skeleton, you need more calcium, and it's normal for it to be high. And it's usually young, healthy people that the normal ranges are created from, actually. So it's misleading. Keep that in mind. If your calcium is in the 10s at your age, then it's probably elevated, and it's most likely that you have this problem. It's a good question. I'm not sure about this one. Can hyperparathyroidism affect the submandibular gland? The answer is hyperparathyroidism, no, cannot affect your submandibular glands in terms of their function. I'm not sure if that's what the question is. Parathyroid glands can be undescended, they can be in some unusual locations, and they can be near the parathyroid glands. So we operate sometimes on people with hyperparathyroidism who have undescended parathyroid tumors that we have to operate near the submandibular gland to remove them. But they don't affect the function of your salivary glands, the submandibular glands, or any of the other salivary glands. Okay, I hope that answers your question. Okay, let's see, this is some of a logistical question. If I fly to your center for surgery, will I need to come back for follow-ups? How many times will I need to travel back? You do not need to come back for any follow-up visits. You will have the cell phone of your surgeon, and so you'll be able to contact me or any of us, for example, if you have questions, etc. There's no hands-on follow-up that you need. You don't have sutures that need to be removed, things of that nature. So it's just the one trip. Most people from out of state will spend 3 days and 2 nights here, part of them. They'll fly in the day before surgery, have their surgery, and then fly home the day after. That's pretty typical, okay? So there's no need for follow-up. You don't have to come back. It's just the one trip to Tampa for the surgery, okay? Okay, let's see. This is a good question. Have you seen chronic kidney disease improve after successful parathyroid surgery? How long would it take? The short answer is no. In general, if damage to the kidneys or declining kidney function related to this disease is not felt to improve after successful treatment. It'll arrest any additional damage or worsening of kidney function, but kidney function doesn't improve back to normal to any degree. It's the same for damage to the vessels to your heart or to your brain. The only thing that improves after successful surgery is bone density. Bone density has been clearly shown to improve in most patients after successful parathyroidectomy, but loss of kidney function, atherosclerotic change to the heart, or cerebral vessels, those don't improve, which is why we advocate for treating this disease when it's diagnosed. It doesn't make sense to wait until you have loss of kidney function to treat this, because they don't get better, okay? An analogy I use with patients commonly when I'm talking about this is hypertension, because if you have hypertension, if you go to your doctor, your blood pressure is really high, they don't say, you have hypertension. When you stroke out for the first time, come back and we'll treat you for your hypertension. They treat you to prevent those things from happening. Because if you don't treat hypertension, you will have a stroke and you'll have a heart attack and your kidneys will fail. Parathyroid disease is the same concept, right? The mechanism of damage to your end organs is different, but it's the same thing. However, patients are often told, well, we'll wait and watch this until your kidneys fail. Okay, it doesn't make sense. So there's no reason to wait until you have damage to your body. If you have a disease, it should be treated. Okay, good question. Here's another one. It's a tough one to answer. What causes parathyroid hyperplasia? So, in most cases of hyperparathyroidism, the disease is caused by a benign tumor growing in one of your parathyroid glands, or sometimes more than one. But that's what the pathology is. It's a neoplasm developing in a parathyroid gland. Parathyroid hyperplasia is a different pathology. It affects all 4 parathyroid glands. They all become enlarged and overactive, but it's not a tumor, it's not a neoplasm that's grown. And in most cases, we don't know what causes it, frankly. There are a couple things, like an earlier question talked about hereditary syndromes, where I was talking about that a little bit, and in those mutations cause parathyroid disease due to parathyroid hyperplasia in every case. All 4 parathyroid glands are hyperplastic, they're enlarged, etc. And so we're not sure why those mutations do this, but they do. Patients who have lithium, who take lithium, long-term lithium use can cause hyperparathyroidism, and it is often due to multi-gland disease. It's a hyperplasia situation as well. So there are some medications known to do it. Genetic mutations for unknown reasons can cause hyperplasia. But we do run into parathyroid hyperplasia in the absence of those things, and the short answer is no one knows why that is. Okay. Oh yeah, there's a good question. Can you address my thyroid nodules during surgery? The answer is yes. Thyroid nodules are really common, particularly in women, and it's, we run into them all the time. It's one of the reasons we do an ultrasound on everybody before surgery to assess these things. The majority of thyroid nodules do not need any treatment. They don't need to be removed. We do not need to do anything about them. Typically, they're benign. They don't cause symptoms. They don't make hormones, so they don't affect the function of your thyroid. They don't really do anything. And they're very common, and they're just there. But in certain cases, if they're large enough, or if they, in the rare case that they're causing symptoms, or certainly if they're suspicious, then yes, we always address the thyroid nodules. They're removed or biopsy, or we send them to pathology to figure out what's going on. It doesn't affect really the time of surgery very much. It doesn't affect your recovery. It doesn't affect the incision size. These are common questions that I get about this. But yes, thyroid nodules can and often are addressed during the operation. My doctor says that hyperparathyroidism doesn't really happen in young people and won't test me. Is this true? No, it isn't true, actually. It's all, just like everything, it's less common in young people, but I've operated on teenagers who have hyperparathyroidism, and then every decade thereafter. So yes, we do see it in teenagers. I think the youngest person I've operated on was 11 years old for this disease. So it can occur. It's unusual. It's less common, but it can. So there's no reason not to evaluate for it. The one thing I'll say about young people with this disease is that calcium levels need to be higher to make the diagnosis. So if you're 50 and your calcium level's 10.8, then you probably have this. But if you're in your teens, it's normal to have calcium levels that high. So we usually like to see your calcium be about 11 milligrams per deciliter at that young age before being sure that you have this. Okay, but yes, you can, even in your teens. That's a good question. I need to wait on surgery until next year for Medicare reasons. What do you recommend for symptoms in the meantime? Unfortunately, there's not a lot you can do for symptoms other than fix this problem. I will say that in some cases, so calcium, just like any electrolyte, is just a concentration in your blood. And so the more hydrated you are, the lower that concentration will be. And so you can really hydrate yourself and get those numbers to come down a bit. And I've had some patients who have reported that has helped them feel better. Their symptoms have lessened or they've felt better because of that. It doesn't work that often, to be honest, but it's possible. You can try it. That's the only thing I know of that I've seen alleviate symptoms other than fixing the problem. Okay. Get another question coming my way. I think we're probably coming to the end. Let's do the last one. All right. This is a tough one. How many parathyroid surgeries should a surgeon have performed to judge their competence? It's hard to put an exact number on that. I mean, there's actually there are numbers that if you look in the literature that denote being an expert in a field. But it's hard to put an actual number on what you're asking. But you do want to ask them how many they do. Ask them how many they do per week. Ask them, the important question to ask your surgeons is how many they do, in my opinion, per week, per month, per year. Okay, get a sense for it. How long they've been practicing. Do they perform their own ultrasound as a surgeon? I think that's really important for being successful. Not in every single case, but in plenty of them. It's a difference between being successful and not doing surgeon before ultrasound. So that's an important question. And what they do, how they conduct their operation. Do they use imaging tests to tell them what to do, to guide, we're gonna do this operation because your imaging tells us this. That's a terrible way to do this, and it often leads to mistakes and unsuccessful surgeries. So I would say those are the important questions to ask. Number of cases per week, month, year, how long they've been doing it. Do they do their own ultrasound, and what's their approach to surgery? Do they do focal surgery and use intraoperative PTH values? Do they use imaging tests to tell them what to do? Those are, if they do, then those are red flags in my opinion. Hope that answers your question, okay? I think that's all the time we have. Sorry for the delay. We had a little technical problem, but glad we figured it out. Thanks for spending some time with me. I hope answering these questions has helped you, and we'll do this again in a month or so. If you have specific questions, really personal and specific to your case, I encourage you to reach out and arrange for a consultation. I'd love to talk to you about it. Go to parathyroid.com, our website, and the intake process for having a consult is really straightforward. Okay? Till next time, have a great evening. All right.